Assalamu alaikum. Welcome back, dear students, to continue our series about sympathomimetics. Today we'll discuss the classification, pharmacological actions, uses, and receptor affinities of these adrenergic drugs. First, let us start with their classification. They are classified into direct acting, indirect acting, and mixed acting. What's direct acting mean? They activate the receptor directly. These agents bind to the receptor and activate the receptor. In direct acting, they don't bind to the receptor, but they can release the norepinephrine like amphetamine, thiamine, or prevent its uptake like cocaine. Direct acting will be either selective drugs that are selective for certain receptor or non-selective ones. Selective includes selective drugs for alpha-1 such as norepinephrine, alpha-2 such as clonidine, beta-1 such as dobutamine, beta-2 such as terbutaline, beta-3 such as mirabegron. Non-selective ones include these drugs such as epinephrine is the parent drug, is the prototype adrenergic drug that activates activates everything. Alpha 1, 2, beta 1, 2, 3, everything. Okay. Norepinephrine is similar except with for beta 2. It's less effective on beta 2. Isoproterenol is selective only on beta receptors, but it's non-selective among the beta receptors that activates beta 1, 2, 3. Okay. The last class is mixed acting that works both by direct acting, such as epinephrine activates alpha and beta receptor, mainly beta receptors, and indirect acting where it releases norepinephrine. More details about these drugs. So again, the direct acting sympathomimetics drugs. Number one, non-selective alpha agonists such as epinephrine and norepinephrine. Non-selective beta agonists such as isoproterenol and the epinephrine itself. We said epinephrine activates also all beta receptors, in addition to all alpha, of course. Selective alpha-1 agonists such as phenylephrine, which is used commonly used as decongestant in cold and cough syrups. Then the selective alpha-2 agonists. Please remember that alpha-2 mainly is presynaptic, and activation of alpha-2 receptors results in inhibition of norepinephrine release. That's why drugs such as clonidine are useful in treatment of hypertension. Selective beta-1 agonists such as dobutamine. Remember, the cardiac adrenergic receptors are beta-1. Okay, selective beta-2 agonists such as salbutamol, terbutaline, albuterol. Okay, remember that bronchial adrenergic receptors are beta-2. Please remember these are very important fundamental facts about these receptors. So finally, just a little recap regarding norepinephrine, epinephrine, and isoproterenol. Epinephrine activates everything, all alpha, all beta. Norepinephrine activates all alpha, beta 1, and beta 3 with very minor effect on beta 2. Isoproterenol activates all beta receptors, beta 1, 2, and 3. More details on these receptor affinities. Phenylephrine activates alpha 1 more than alpha 2, and this affects much more than beta. So that's why it's selective alpha 1 agonist. This actually just draws your attention to the fact that there is nothing absolute. You cannot say it's only active at alpha 1, no effect at all on alpha 2 or beta. It's just some selectivity. Clonidine is the opposite regarding the alpha receptors, alpha 2 more than alpha 1. Mixed alpha and beta agonists such as the parent drug epinephrine activates everything. Alpha 2 similar to alpha 1 similar to alpha 2, beta 1 similar to beta 2. Norepinephrine, as we said, similar to epinephrine on the alpha, but with more effect on the beta 1 than beta 2. Beta agonists. Number one, beta 1. Okay, the selective agonist is dobutamine more than beta 1 more than beta 2. Isoproterenol, also called isoprenaline, please remember this fact. Okay, it's non-selective on beta 1, 2, and 3. These anti-asthma drugs, including albuterol, terbutaline, salbutamol, activates more beta 2. Dopamine agonists include dopamine, which activates D1 and D2 receptors, way more than beta and alpha receptors. But there is the selective D1 receptor agonist, phenoldiazepam, which, as I said before, is used in treatment of hypertension. Then the second category is indirect acting sympathomimetics. These agents, as we said, inhibit the reuptake of norepinephrine into noradrenergic neurons, such as cocaine. Okay, hence norepinephrine is not inactivated and has prolonged action on both alpha and beta receptors, or facilitate norepinephrine release. This one prevents the uptake, so it does not go back to the nerve ending. But this one facilitates the release of the neurotransmitter norepinephrine. These drugs, such as tyramine, enter noradrenergic neurons and cause norepinephrine release. Tyramine, by the way, is present naturally in cheese, specifically aged cheese. Or slow norepinephrine breakdown by MAO, such as the MAO inhibitors, including tranylcypromine, which is used in treatment of depression. The last thing is maybe the drug exert all the three effects: inhibit reuptake, facilitate norepinephrine release, slow or inhibit MAO, such as amphetamine and methamphetamine. Because these drugs depend on the stores of norepinephrine, the norepinephrine that's stored in the presynaptic nerve ending vesicles. So these drugs are liable to cause or for tachyphylaxis. Tachyphylaxis means loss of drug's effect when it's given continuously or over a long period. So if these stores are depleted, the effect will diminish, and this is what happened, that the effect diminish over time when vesicular stores of norepinephrine are depleted. The last category is dual or mixed acting sympathomimetics, such as ephedrine. Ephedrine is natural. It's from a plant called ephedra. Again, we said mixed. So number one, it facilitates the release of norepinephrine. Number two, the direct effect is to activate beta receptors with some effect on the alpha receptor. This accounts for its early use in asthma. Okay, now for individual drugs. Number one, of course, we need to start with epinephrine or adrenaline, same, right? It's a hormone secreted by the adrenal medulla hormone. It's a hormone secreted by the medulla because it's secreted by gland and into the blood where it goes everywhere. It's very potent cardiac stimulant, activates, we said, beta 1 receptor in the heart, so it will activate the cardiac contractility and heart rate, and activate alpha receptors in the vascular beds, causing vasoconstriction. That's why its effect on blood pressure is kind of, I would say, just take it slow. Okay, so on the systolic blood pressure, what happens? Okay, the blood pressure equals cardiac output times peripheral resistance, right? And cardiac output equals heart rate times stroke volume, right? So this adrenaline, it has positive inotropic effect, means it increases the cardiac contractility, right? This will increase the pumping action of the heart. This will increase the stroke volume and also increase heart rate, right? So heart rate times stroke volume, this will increase the cardiac output, and blood pressure equals cardiac output times the peripheral resistance. It also increases peripheral resistance by its effect on the alpha receptors, causing vasoconstriction. So all of these will lead to increase in systolic blood pressure. However, it activates beta 2 receptors in some vessels. Do you remember when we said the sympathetic nervous system has this weird effect on blood vessels? Kind of say to the organs like viscera, like skin, could you please allow me to take some of your blood and divert it and give it to the skeletal muscle because it needs it more? So this is what happens through the beta 2 receptors. So here, vasoconstriction on maybe the viscera, skin, whatever, and dilatation of the skeletal muscle blood vessel. This will cause their dilatation and increase blood flow during exercise. That's why the total peripheral resistance may fall. This will explain the fall in the systolic blood pressure seen with epinephrine. So now in epinephrine, as just a recap, it increases systolic blood pressure and decreases diastolic blood pressure. Used to treat ventricular fibrillation arrest and other forms of cardiac arrest as life-saving. It's indicated also for treatment of acute anaphylactic shock, like a patient receives penicillin when this same patient has hypersensitivity against penicillin. So this may cause angiogen antibody reaction on the surface of mast cells, the release of histamine, vasodilation, and maybe severe hypotension and collapse, maybe death. Okay, so the life-saving drug is adrenaline in this case, followed by corticosteroid. It's used also with local anesthetics to prolong their action. What happens here, you are not using adrenaline for its cardiac stimulant effect, for heart rate or positive chronotropic effect. No, you are just using a small dose with local anesthetic and are injected on the site, like the dentist when they use lidocaine along with adrenaline. So you need the lidocaine to just be limited to the mouth of the patient. So now the drug will be concentrated at the site of effect, site of action, and also it will limit the leakage of the drug to the other unwanted sites. So the lidocaine will not go to the heart, cause dysrhythmia and other side effects. So it's very good and very common use in this indication. It's contraindicated in hypertensive patients because, as we said, increased blood pressure, right? The systolic blood pressure. Hyperthyroid patients with thyroid hormone self increase heart rate, increase cardiac contractility, and angina patients because this will increase the cardiac oxygen demand, okay, cardiac load and cardiac heart rate, contractility. This will increase oxygen demand, and angina patients, they suffer from decreased oxygen supply. It should not be given to patients receiving beta blockers. As we said, the effect of adrenaline on blood vessels, on alpha receptor causes vasoconstriction, on beta receptors causes vasodilation. If you block the vasodilating effect of adrenaline by propranolol or any beta blocker, the only remaining effect on blood vessels will be exerted by its effect on alpha-1 receptors, which will cause severe increase in peripheral resistance associated with marked rise in blood pressure. The second drug is norepinephrine, also called noradrenaline. It's released by sympathetic nerve terminals. It's similar to norepinephrine, except it has little effect on beta-2 receptors. Regarding blood pressure, it increased everything. Okay, it does not have effect on the beta-2. Remember, right? So beta-2 was the one was causing some confusion regarding adrenaline. I think adrenaline increases systolic but decreases diastolic. Here there is no or mild effect on beta-2. So everything will increase diastolic and systolic blood pressure. However, heart rate, because there is some reflex bradycardia, okay, so the heart rate may decrease, okay, but the positive inotropic effect will be maintained. The third drug is isoproterenol, or also called isoprenaline. So all these drugs has two names, right? Adrenaline, or epinephrine, noradrenaline, norepinephrine, isoprenaline, isoproterenol. It's a synthetic derivative of norepinephrine. It's very potent beta receptor agonist only, right? No effect on alpha, okay? Or little effect. It activates beta receptor almost exclusively, so it's potent vasodilator. So it has positive chronotropic and inotropic effect. Okay. So regarding the blood pressure, it increases cardiac output. Okay. But it's associated with fall in diastolic and mean blood pressure due to its effect on the beta receptors, specifically beta 2, with no change on the systolic blood pressure. Okay. It's indicated for episodes of heart block that do not require electric shock. So now comparison between the three drugs, norepinephrine, epinephrine, and isoproterenol effect on the heart. Number one, we said norepinephrine has effects on alpha, okay, receptors, so it will increase the vasoconstriction, so systolic blood pressure will increase. but does not have so much effect on beta 2. It's so the effect on the systolic blood pressure, also the systolic pressure will increase due to the increase in effect on beta 1 and increasing cardiac contractility and heart rate, and the whole blood pressure will increase. And also it will increase the effect. It has effect on alpha receptor, causing severe vasoconstriction. So also it will cause increase in the systolic blood pressure. However, as we said, it suffers from reflex bradycardia. Okay, so heart rate will decrease. Epinephrine, we said it increases the systolic blood pressure, whereas decreases the systolic blood pressure due to the effect on the beta 2 receptors in the skeletal muscle, which will decrease the systolic blood pressure. Heart rate, of course, will increase due to the effect on beta 1 receptors. Isoproterenol, the effect on blood pressure is almost no change, but the effect on the systolic blood pressure will decrease due to the effect on beta more than alpha receptors, and heart rate will increase. The second or the next drug is dopamine. Okay, it's the immediate precursor of norepinephrine. Do you remember we said norepinephrine, when it's sensitized, we start with tyrosine, which is converted into dopa. Dopa is converted into dopamine, and dopamine then is converted into norepinephrine. So it's the immediate precursor of norepinephrine. It activates D1 receptors in several vascular beds. It also activates presynaptic D2 receptors, which suppress norepinephrine release. You remember, do you notice something? So D2 receptors activation suppress norepinephrine release, and also alpha 2 receptors activation suppress norepinephrine release. Just something to remember. It activates also its beta 1 receptor in the heart, so it will increase the heart rate and contractility. At low doses, peripheral resistance may decrease, okay, because of this vasodilatation and inhibition of norepinephrine release. However, if you increase the dose, it can activate alpha receptors, which lead to vasoconstriction and including the renal vascular beds. It's indicated for correction of hemodynamic imbalance present in the shock, generally speaking, due to myocardial infarction, trauma, endotoxic septicemia. I brought this intentionally, dobutamine, the same page, because they look similar. However, they are not similar. Okay, so this one has nothing to do with the dopaminergic receptor. It's beta 1 selective among the beta receptors, and it also alpha 1 selective. It's indicated for patients with acute hypotensive heart failure or shock. Ephedrine, if you remember, we said it's dual acting, right? So it, number one, enter the noradrenaline neurons and facilitate the norepinephrine release, and also to activate beta receptors with some effect on alpha receptors. Okay. Because it's not catechol derivative. Do you remember we talked about catecholamines, adrenaline, noradrenaline, dopamine, isoproterenol, all of these are catecholamines. This guy is not a catecholamine. So it's not a metabolite for COMT, COMT, catechol-O-methyltransferase. This will increase its bioavailability and increase its duration of action. Its ability to activate beta receptor accounted for its earlier use in asthma. However, it is, it has CNS stimulant effect, as you see here, and also it is non-selective with regard to beta receptor, so it will have many side effects. That's why it has been greatly replaced by beta 2 receptor agonists such as salbutamol, terbutaline, albuterol. Enantiomer of this drug, enantiomer means it's similar in the chemistry, the atoms are similar, but it's different in the stereochemistry. So it's available over the counter as a component of many decongestant mixture. You see the cold and cough syrup, mostly they contain pseudoephedrine. How it exerts its decongestant effect? Because it has alpha adrenergic agonist effect, causes vasoconstriction, and also it facilitates the release of norepinephrine, which again will cause vasoconstriction. Then phenylephrine. They look similar, but they are not. Okay, so it's selective alpha 1 agonist. Okay, So it's not a catechol derivative. Again, it's not metabolite for COMT, so it has long duration of action. It's effective mydriatic and decongestant. Again, it's present in many cold and cough syrups. Okay, we sometimes used to raise blood pressure in hypertensive patients. That's it for today. Thank you so much for your attention, and please enjoy and say Subhanallah wa bihamdih, Subhanallah al-Azim. Wassalamu alaikum wa rahmatullahi wa barakatuh.